This is the NP Advocate podcast, where frontline clinicians share the real human stories behind the barriers in our healthcare system. These nurse practitioners are powerful advocates for themselves, their profession, and most importantly, for their patients. I'm Laura Starr, fellow nurse practitioner, and your host. Welcome to the NP Advocate. Hi, Erna. Welcome to the podcast.
Hi, Laura. So excited to do this. It's been a long time coming.
I know.
So
I'm
happy
excited
to be here.
I'm excited too. I'm super thrilled to talk to you. I know we've interacted in the past. This is a bit of a niche issue, but I think it has really big implications. And I'm also excited to learn more about you. Can you tell me what kind of role you're in right now in the nursing world?
Sure. So I've been a nurse for over 30 years, but most of that career has been as a neonatal nurse practitioner. And I have practiced in pretty much entirely, mostly in the San Francisco Bay Area, and I love it. I mean, I'm truly blessed that really for most of my career, I jump out of bed and want to go to work. So I'm absolutely, blessed that I chose this career, that I still love it, still want to contribute.
Awesome. Where did you go? I don't meet many neonatal nurse practitioners. Where did you go to school? You're like, I don't either.
It's a pretty small subspecialty, right?
Yeah.
And that's part of what makes it exciting, I think. I got my undergrad down in Southern California at Loma Linda University. So that was it's a great academic medical center. So I got a lot of exposure, including this was over 30 years ago, I worked with some amazing nurse practitioners in the NICU, in the newborn ICU back then. And I knew almost right away that's what I want to do. So shout out to all of them for inspiring me to go ahead and get my master's degree from the University of California in San Francisco.
I see. So you moved up to San Francisco, got your master's, and kind of never left. Is that essentially what happened?
Pretty much. Literally.
Nice.
I have been here ever since.
There's a lot of, I've been critical care on the adult side. I imagine you've seen a lot of changes in neonatal practice in the time you've been practicing.
I have. It's been an incredible journey since I first started as a green, and I was a nurse. So I started out in the NICU as a nurse, and I did that, full-time night shift, like we all started out back then, for 2 years. And then I moved and started grad school. So I didn't have this extensive bedside nursing experience. I had some, and it was an amazing place. I got to see and do a lot of things. It was a level 4 NICU. And then I moved into another large academic medical center, University of California, San Francisco. And yes, I started out super green. And I really want to encourage anyone who's in nursing, not in nursing yet, that we all start somewhere and we all grow and use every single experience to mature as nursing professionals. And that's a definite. So yeah, I've seen huge changes. Really, the practice is not exactly completely different from what it was when I started, but there have been big changes, little changes, and believe it or not, I've worked in one of the many places that I've worked as a neonatal nurse practitioner. I still work today, and I started in 1995 when I graduated, and still work there.
What made you pick nursing? Was it just always like that thing you were going to do? Do you come from a family of nurses?
No, I didn't. I come from a family of teachers and educators, but I always wanted to go into the medical field. I was in high school, and I was like, at first I wanted to be a pediatrician, and I always knew it was going to be in pediatric kids. So I left after high school and left home and went straight to nursing school. It was just a really great option, and it still is. When you're coming out of high school and you're interested in health sciences and just helping people, and blood and all that stuff doesn't scare you too much. I knew pretty early on I wanted to go into the medical field, the health field, and the opportunity to go to nursing school was just it was just an easier step for me. So I took it. and I happen to regret it.
What does a normal day look like for a neonatal nurse practitioner?
Oh, that's a great question. The day in a life. We actually have this written down.
Oh,
So
that's
we
nice.
do it. It's
Yeah,
called a day in a life.
I like literally like you go to conferences, like there's the occasional pediatric NP, but like there are not a lot of you guys.
No.
So I'm
No.
gonna take the
It's
opportunity.
tiny. Oh, sure. Yeah, what we do, so we work in a critical care unit, and it's almost always the largest critical care unit in any hospital because, babies, they're pretty small and they don't take up as much space as, say, an adult. So, plus, people are having babies all the time, everywhere, right? So, in a nutshell, I could go on all day about this because I just love what I do. But in a nutshell, it's a critical care unit. We take care of any newborn from birth, from the time the placenta is cut. Literally, the moment it's cut, one of us sometimes is catching the baby, whether it's a C-section or a vaginal delivery. So from the time that baby is cut, we are trained and credentialed to take care of anything up until the baby's 2 years old. So most of that is in a NICU. Most nurse practitioners, not all, but most neonatal nurse practitioners work in a NICU. And so if the baby needs to be in a NICU, something's not quite right, obviously. If they don't have an opportunity to stay with mom and go home with mom after birth, they need to get some kind of care or monitoring. Sometimes it's pretty low acuity, and sometimes it gets extremely high, all the way up to lung and heart bypass or ECMO. So we do all of it. So a day in the life is usually we come in, we get sign out from the person who's on taking care of a team of babies the night before. We look at the baby's chart. We look at the patients that we have taken care of that day. We pre-round or collect all the information, come up with a plan. Then we round with a team, and it's usually a very multidisciplinary, interdisciplinary team of other care members that are very experienced taking care of ill newborns. And then we execute the plan that the team comes up with, and we spend the rest of the day executing that plan. And of course, bringing the family along with that plan. That's a huge, huge part of what we do. As you can imagine, every NICU admission is never a family's first option or idea. Nobody wants their baby. They need NICU care, but we're there when and if it's needed. And we really want to have the family do this with us. And there are lots of ways that they can take care of their baby with us and help us make decisions. So we spend pretty much our entire day after rounds executing that plan and making sure the family is aware of that plan. But it's fun. We do a lot of procedures too, and which is of course exciting. But most of what we do is making lots of really hard decisions and entering a lot of orders. That's
That
it in a
sounds.
nutshell.
It sounds so similar to like my critical care, my adult
Yep.
critical care days, but just the fact that there's babies.
I
Someone's
hear
got to
that a
do
lot.
it.
Yeah, and we love it. We absolutely, just like you love adult critical care or pediatric critical care. I mean, everybody has to find their niche. It's not for everyone, of course. I couldn't do what you do. Absolutely not. Absolutely not. But I'm glad that I love it.
Awesome. Well, I know we met, we sort of came on each other's radars, through sort of a health policy discussion, called the California Children's Services. There's some issues with the way that program's administered. Can you tell me a little bit more about what CCS is?
Oh, sure. I'll give you a little nutshell, and then, if you would like, I'll segue into why on earth did I become involved in policy from California Children's Services. So CCS is a state and federally funded program that is under the Department of Healthcare Services in California. And the Department of Healthcare Services is sort of the overall branch of our state government that's commissioned to use the funds provided by the state government to distribute and to curate and to administer programs throughout the state of California to help the residents of California who may not be able to afford it. So CCS is one of many programs administered by the Department of Healthcare Services. The CCS is specifically for children or residents of California under the age of 21 who have certain medical conditions or diagnoses. Some of them are very complex, as you can imagine, and they need very, very specific coordination of services and referral to services because of those medical conditions. So this is a program that's been around for 100 years. I believe they're going to celebrate their 100th anniversary in 2027.
Wow, I did not know that. That's crazy.
I didn't until most recently either, which is absolutely crazy. So they've been around and doing really good work for a very, very niche and very, very small population of California, but who need a lot of medical care. So throughout California, usually associated with certain clinics or health systems, there are CCS special care centers that provide very specific coordination, referral of specific services to those children who meet the eligibility criteria for CCS.
So I guess I'm imagining like children with like genetic syndromes or congenital heart disease or
Correct.
like something along those lines. Yeah.
Yes, those are just a few of a long list of examples, and they have a very specific list. You have to meet the criteria, and they have that all spelled out on their website. What are the conditions that they can meet? And as you can imagine, a lot of those patients spend the first days, weeks, and months of their life in NICUs. So many NICUs are also special care centers. NICUs have actually a special CCS designation if they choose to apply for CCS funds or reimbursement for the care in that NICU. So yes, they're all very closely linked. But yes, many of those children in California are in our communities were once in the NICU. Not all of them.
So like a sample, I imagine that like UCSF is, participating in the program, et cetera. So you probably deal with this on the day to day.
Yeah, I do.
So like a baby gets born with I'll just get, cause I'm more familiar, a congenital heart disease, and they're going to need support, in the NICU and at home. So they're born, now they're your patient, you see them. What is like, how does that affect your, like, how is CCS involved in your day to day?
So as far as being a nurse practitioner in the NICU, CCS is not very involved in my day-to-day work. Where this really comes to light is for the family. So the even in the NICU, each child should have or will have a CCS eligible medical condition. So I'll give you one example. You brought up one congenital heart disease. Not every congenital heart disease condition would be eligible for CCS. As you can imagine, some are very mild and some much more complex that require, say, surgery, heart surgery before they even go home for the first time. But say you're born very premature. That's like the bread and butter of neonatology. Is you're born very premature and you're in the NICU for many, many months, and you have respiratory or breathing problems. So you have several diagnoses related to the respiratory system. Or because of your prematurity, you have retinopathy of prematurity, which is a condition of the eyes. Because you're born premature and exposed to some interventions in the NICU, your vessels do not mature in the normal fashion, and you can have a condition called retinopathy of prematurity, which increases the risk of blindness. So that is just one example. So after a baby is exposed to those interventions or is at high risk for retinopathy of prematurity, or for those babies who do get retinopathy maturity and need very close follow-up by a pediatric ophthalmologist, those patients may be eligible to go to a CCS, a special CCS program, or their care after leaving the NICU could be reimbursed by CCS because they meet CCS eligibility requirements. Or a baby goes home because they need oxygen because, again, they have respiratory problems or chronic lung disease because they're born premature, lots of other risk factors. They will then need to go to see a pulmonologist because they go home on oxygen, and someone really needs to help their pediatrician follow these conditions as they grow up. So those are just, I can go on and give you other examples, but those are just some of the examples of how CPS becomes very, very important, especially for the family, for the case managers who really deal with making sure the families are well covered, so that their child's care is well covered by the appropriate agency, by the appropriate financial institution or insurance, etc. CCS really does come into play even before they go home, just to make sure if this baby has a CCS eligible condition, we need to make sure that the health system was reimbursed accordingly.
Well, that sounds great. Having a sort of healthy non-NICU stay baby is stressful enough. I can only imagine having one that has, complex health needs. So it's like, this sounds great on paper. What does it look like for you? What are some of maybe the things that could be improved?
So as far as CCS is concerned, or in general? Oh, okay. So I'll answer that question by using another example. It's called, one of the CCS special care centers, it's called a high-risk infant follow-up. It may be called something a little bit different depending on where you are, but for the most part, it's called a follow-up clinic. And the purpose of that clinic, and the reason that it is usually a CCS special care center, is because patients are seen there, and this is all mandated by CCS. CCS really lays out what their special care centers can do, should do, and who should do it. In other words, what types of staff should be a part of this special care center core team that should see these types of patients. So the high-risk infant follow program or clinic is one of those many. There are many examples, but this is one. And all of the high-risk infant follow-up clients usually come through the NICU. And what that is if a patient has these diagnoses or these risk factors that can affect their cognitive or physical development as they grow up in those early years of life, they're super important that we follow and track development in the first few years of life to make sure that there aren't any therapies, services that they are missing that could really help them maximize their potential, whatever that is. So the high-risk infant follow-up is mandated to see certain patients that are discharged from the NICU in certain intervals. For example, some patients may need to be seen by a CCS-eligible pediatrician, a nurse coordinator, and a whole core team annually within the first 6 months for the first year and annually for the first 3 years. And really what those visits are, they are very detailed cognitive and physical assessments of this client, this child that has come out from whatever the reason for the NICU stay is. And they do very, very detailed developmental assessments in the first 3 years of life in certain intervals. And every time they are seen by the developmental specialists and the nurse practitioner. We have many nurse practitioners who work in CCS programs throughout the state, and certainly where I work as well. And every time they're assessed, they come together as a team and say, what do you think this assessment showed us? And what are the types of services, whether they're PT services, OT services, nutrition services, or any services that they think can really help this child to continue to develop as much as possible. Let's place some referrals for those services. Let's make sure they see these services. And so these have been very well documented to help decrease readmissions, to help with just making sure that development is optimized and that they're not falling through the cracks and falling through. So this is different and above their primary care, which they absolutely should see. So this is extra services, extra assessment at certain specific intervals to make sure in the first 3 years of life, this is specific to high risk follow-up, so that their development is very closely monitored. And it's something that is extremely important to families, as you can imagine. If I didn't mention this before, to be CCS eligible, we must meet an income threshold as well. So you must be eligible for Medi-Cal because this is, again, funded by state funds. So the high-risk infant follow-up clinic, like I said, is just one example of how important the special care centers are and how important having the right staff with the right training in those centers will maximize the outcomes for it.
Yeah. And I know it sounds like you're largely handing people off to that service, but does that handoff go well? Is there any bumps in the road that you've experienced?
No, that is pretty well worked out, especially when we're working in the NICU. There's usually always someone before the patient is discharged. We have a huge checklist, a discharge checklist. And one of the important pieces of that checklist is to make sure that they have the appropriate referrals, outpatient referrals. And one of them is, do they qualify? And if they are qualified, do they have a referral to the high-risk infant follow-up clinic, for example? Or do they have an appointment or a referral that's ordered, that I order as a nurse practitioner in the NICU? I do this all the time, and my team does this all the time, is we refer to the cardiology clinic, to the high-risk infant follow-up clinic, to whatever that patient actually needs. So that's a very important part in the continuity and the continuum of care for a patient, for example, who's in the NICU and is then discharged to home, but they're also discharged to a community. They're discharged to somewhere where they will no longer have 24/7 nurses, doctors, nurse practitioners caring for them. So that handoff or that transition to care is so important. So how we discharge every patient that leaves the NICU is extremely important. So we have a lot of processes in place that help us make sure that transition is as smooth as possible.
That sounds great. I'm glad to hear that. That sounds relatively smooth. I'm sorry. I was reading some of the regulations. They call them numbered letters for CCS, and I know there's been some problems with them recognizing nurse practitioner signatures. Is that something that you run into in your practice?
I don't, because I am an inpatient nurse practitioner. But where I do run into it is, and I may not have mentioned this before, is my current job, the current hat that I'm wearing. I'm an advanced practice manager, so I manage a team of nurse practitioners in several departments in our health system, and one of them is the high-risk infant follow-up clinic. So as part of that role, I manage and sort of oversee how my nurse practitioner in the high-risk infant follow-up clinic is, what's her scope of practice, what's her workflow, and how can we optimize her practice. And in that role, I very quickly found out that some of her functions are impeded by what you just referred to. It's called a numbered letter. Numbered letters are simply the policies that this department, CCS, have implemented to run their program. And they have regulations in place, and they have the authority to create these policies and to audit their programs. And so one of these numbered letters, they have many, And you can easily Google this, and you can go on Google and search CCS numbered letters, and you'll go to a site that lists all of them going back, decades. One of them uh, is called Requirements for Nurse Practitioners in CCS Special Care Centers. And what that numbered letter, it looks like a memo, to be honest. What that numbered letter outlines is the reason for this numbered letter. And these are the specific requirements or functions that nurse practitioners in CCS Special Care Centers can do, and this is what they cannot do. So yes, one of those requirements is one of many, and most of them have a similar sort of reasoning or function. One of them is that a nurse practitioner in a CCS Special Care Center, so they're not dealing with nurse practitioners in any other clinics or healthcare centers or anywhere else. If this is a CCS Special Care Center, a nurse practitioner must have all of their changes in plan of care. So if there's any change, they've seen a patient as part of a CCS visit, and there needs to be a plan of care. It must be approved and co-signed by a physician within a certain period. And that's true for several things, including their referrals for services. That those referrals must be approved and documented by a physician, so it cannot be independent assessment, evaluation, and then a referral placed by a nurse practitioner in a CCS Special Care Center. And that's a problem. And I can jump right into one of the biggest reasons that is a problem is that our Board of Registered Nursing in the state of California is truly the only organization that is mandated by the state to describe, to outline what a nurse practitioner can and cannot do. And there are certain stipulations for nurse practitioners in the state, and every nurse practitioner really should have a good idea of what that is, because the BRN is the only authority on practicing nurse practitioners in California. And we can go on to, there's sort of another step in that scope of practice, but it first comes from the state. Your scope of practice comes from the Board of Registered Nurses in California. And if any policy contradicts that or restricts that any further, that's a problem. So this CCS numbered letter says that I cannot independently assess and evaluate and then refer a patient to services without the approval, post-signature documentation, separate documentation by a physician in that special.
So can NPs even have an independent visit? Like I'm curious how that works in real life.
Ooh, that is a whole, we could have a whole other conversation about that. But and I know you probably are well aware that in the state of California, nurse practitioners, they are now, as of 2023, there are now several different types of nurse practitioners. So a nurse practitioner can be a nurse practitioner that practices with a BRN license and with standardized procedures and with a supervising physician. So those are, and I'm trying to keep this as simple as possible. Sometimes a lot of this language, regulatory language, can be very daunting and intimidating. And this was me probably 10 years ago, 5 or 10 years ago, just being, this is too complicated. I can't do it. But that truly is kind of the umbrella. You are licensed by the state of California as a nurse practitioner. Every nurse practitioner can do that. So the BRN will make sure you have the education, the credentialing in your specific population, etc. And then they will issue you a license, and they will say that you have a license to practice in this population in the state of California. You must have standardized procedures to perform medical functions, and you must have a supervising physician. So in addition to that, a couple years ago, this is newer in California, the BRN sort of eliminated some of those. It's called a 103 and a 104 NP. And I don't know how deeply you want to dive into those. And I'm no expert. I'm really not an expert in this at all. We have many people in the state at California Association of Nurse Practitioners has an incredible policy committee and lots of people. And you, Laura, I know you are very well versed in this, but so we now have the opportunity to become licensed as a 103 NP. And what that does is you have to have the NP license first. And then if you demonstrate certain requirements like a transition to practice hours, and I won't want to get down into what may happen to that, certain transition to practice hours that demonstrates that I have experienced this many, I think it's 4,600 hours of experience in this population, I'm board certified, etc. Now I can practice as an NP in California without a supervisor position and without standardized procedures, but I still have to do that within a healthcare system or clinic or program where there is a physician present. But at least it does get rid of the need for standardized procedures and a supervising position. So that's one level. The 104 takes it a little step further, is that you can be 100% independent and practice on your own without having a physician as part of your practice or in wherever you are hanging your shingle, so to speak, and we do not need standardized procedures or supervising. So 104 is as close as we so far have gotten in California to full scope of practice or independent. So it's possible. We're on we're on the trajectory to getting there, but that's where we are today. And more is coming, I think, from the legislative and regulatory. So I didn't want to delve too deep into it. I hope that answered your question.
I get like back to sort of in a CCS specific environment, if they're requiring a physician co-signature, like that's, even when I'm practicing under standards procedures, depends on my employer. Like if I see a patient in clinic and I decide that they would benefit from a physical therapy referral or maybe a nutrition referral, then I place the referral and I move on with my life.
Right.
So I'm curious how that and my standardized procedures are fine with that. So
Correct.
requiring the co-signature, and I work with surgeons. They can their Epic inbox gives me anxiety. Like they don't read things. So right. those orders aren't getting co-signed. Like I'm curious what that looks like in your world. And how what's the workaround here?
Exactly. That is why the numbered letter is incongruent with the Nurse Practice Act in California. That's it. You just laid it out beautifully. So in one area, I can assess a patient, I can evaluate them, come up with a plan, put that plan, order whatever that client needs, and move on. In a CCS special care center, a nurse practitioner is not able to do that. Mm-hmm. So that's a problem.
Yeah.
That's absolutely a problem.
I mean, correct me if I'm wrong. We talked about this in the first part. There aren't a ton of nurse practitioners or frankly physicians that are trained and specialize in this particular area. So I imagine cutting a huge part of them out of the team by sort of hobbling them this way is difficult. So I mean, you still have NPs practicing in this area. It just is extra.
They're limited.
Yeah. Does it I'm just imagining what kind of problems does this end up causing in real life?
So in real life, it causes problems from an operational standpoint in the program, as you can imagine. Who can you hire as a nurse practitioner? Should you hire a nurse practitioner with these requirements? Because obviously you absolutely have to have a physician, which is great. You'll have a physician, but they apparently need to see every patient at least annually in that special care center. But should you hire a nurse practitioner who's trained, qualified, educated, and credentialed can they be used in the same special care center, or is their scope of practice going to be limited because they need to have co-signatures? So a lot of this is can end up being a lot of duplicative work, or the potential is there for duplicative work, and that's a cost that no one can afford, and no one should have to do that. So remember, these are programs that are funded by the state and the federal government partially, so and local funds as well. So these programs need to be run, one, efficiently, and one, from an economic standpoint. We really need to make sure that they're not burdened from an administrative and a budgetary thing. So that's one thing. The other thing is that, like we said earlier, our scope of practice is limited. And that should not happen. I think we have all remember that we've been commissioned for many, many years, whether it's on the Institute of Medicine, the Future of Nursing reports, that we need to run our programs in a timely, efficient, and patient-centered way so that they're not waiting in an exorbitant or time to see a qualified provider when a nurse practitioner can do it, but the nurse practitioner is limited in their scope in the special care center to see this patient and really get them the referrals they need in a timely fashion, because they have to wait for the physician to see the patient, create their own visit and document, etc., and then co-sign this note or co-sign a change in the plan of care that the nurse practitioner has already assessed and evaluated. So it really does create a cumbersome system. It creates a lot of duplicative care, and that's something that no one should have to do when a nurse practitioner, again, by the state of California, is educated, credentialed, and qualified to do this same work. If they meet those requirements, that should be enough. So having these requirements put on by another program is really incongruent with the statute. And this is something I learned from some recent work I've been doing. Actually, I'm in a doctoral program, and this is what I have been doing, is analyzing this particular policy and really sharing with stakeholders and having conversations that, just like you and I are having, how is this impacting the programs? How is this impacting the clients? Are you meeting any roadblocks or barriers to the purpose of your program as you try to take care of your community? So I've had several of those conversations, and these are what I'm telling you and sharing with you is literally what I've been hearing from those. So it is a problem, and for CCS, it is a problem, and I'm hoping that having these conversations with the California Association of Nurse Practitioners, with other stakeholders like the CCS Advisory Group, which meets every quarter and is open for the public. I have joined many of their meetings just to listen in to their process and to help make it less daunting. I think you just have to be in the spaces and listen to conversations, and listen to people's stories. And that's what I've been trying to do more of, so that I understand where is this coming from and what should we be doing about it. And having a conversation with you is just one of those.
Where do you think it's coming from? Like the co-signature requirement, I think predates my birth for nurse practitioners in California.
Mm-hmm.
Do you have a sense of sort of where, did someone think it was required, or is it just sort of an oversight or misinformation? Where do you think that these, I guess, regulations, for lack of a better word, came from?
Yeah, that's a great question, and I wish I knew the answer. So, unfortunately, and I did a fair amount of digging on the CCS website to answer that question. I said, okay, what are the discussions in the meetings that were had before and around when this numbered letter was suggested, when it was created, and when it was put into effect? Someone had to come up with this idea, right? Every policy starts with an idea and or a problem that someone wants to try and solve from a regulatory standpoint. All of them start that way. So I couldn't find that record. unfortunate. Historically, I maybe it's just not for public access.
Mm-hmm.
That could be it. But just listening to some of the conversations I have been a part of, starting early last year, in 2025, when I started to ask questions of CCS programs, when I started to attend CCS advisory group meetings, and that's a group within CCS that offers suggestions and offers advice to CCS on things like regulatory policy, like the member. So as part of that, I can infer, and that would be all it is because I don't have the evidence, the documented evidence, but I can infer that a lot of it has to do with not really knowing enough about the nurse practitioner role. And this is something I think nurse practitioners, I've heard this in many forums from many NPs. So I don't want to speak for every nurse practitioner at all, but I have heard this many times. And this is across the country. A lot of our colleagues in other roles don't fully understand what we do or what we can do, what our scope of practice is, what we can deliver and how we can help the healthcare system, how we can help our clients. A lot of the people we work, even though nurse practitioner, the role has been around for not 50 years or something like that.
I think it started. I think it was the 60s.
I think it was late 60s, early 70s. Yes, it was in its infancy. But yeah, we've heard it then. So we've been around for a long time, and yet we are still a relatively young part of the healthcare system in this country. The medical system has been around for centuries. I mean, I'm talking about an organized medical system, at least a century or more. And other disciplines within healthcare have been around for very long. And those disciplines have had their own regulations and their own policy that can affect the nursing profession and can affect nurse practitioners' scope of practice. So a lot of what I have heard and the conversations I've had is that there's just not very clear understanding of a role, what we can do within the state of California, what the Nurse Practice Act says we can do. And then there just is some disagreement with that scope of practice. Some people who disagree with what we can do and don't want us, or feel as if we're stepping into other disciplines sort of wheelhouse, so to speak. So, and that is unfortunate. I can even understand why they think we're sort of stepping into other areas. I mean, at the end of the day, we all want to take care of patients. We want to do it well. We want to do it in an evidence-based way with the information we have at that time. We all want what's best for our patients. But I think the human being also can't help but, this is what I do and no one can do it better than I. I think that's sort of a human condition. And I'm not making excuses for it at all. But I think at the end of the day, people truly feel threatened by anything that looks similar to them or that may appear to be doing what they can and or should be doing. So the nurse practitioner role has dealt with this since it was started many decades ago. I have seen it in my entire career in different shapes and forms. It's manifested in different ways. And looking at this CCS policy, talking about why would CCS even think this is needed or necessary? Did something happen? Was there an event, or was there someone brought some concern and they had to be or an idea or thought there was a problem that needed this policy, and this is how they chose. This is how they chose after much discussion, because you can imagine there's a process to come up with a number. Never. It's not just someone types up something overnight and in the next meeting it's voted. No, there's a process to it. There's discussion. It's open to public comment even. So whether those things, there was an actual discussion, if all stakeholders were part of that discussion is unclear. It's very unclear when this was first brought to CCS. So I think moving forward, though, what can we do moving forward when we do have a policy that restricts our scope of practice, that is incongruent with the statute, which is the ultimate authority, by the way? This is one thing I've also learned, is that programs, policy, and regulations cannot contradict statutory law. They can't. They are breaking the law if they do, when we really shouldn't do that. So there's that sort of sticky place. And how does one have a discussion about that with a program? We totally know that they don't mean it with malintent, but it could be a problem, and they need to be aware of that if we think that is the case.
Mm-hmm. Yeah, it's so easy to fall into like an us versus them mentality, but
yes,
it is important to remember that everyone's, at least I'm going to say the vast majority of the time, everyone is approaching this from a place of wanting to do right by the patients.
Absolutely.
And so that's a good place to meet in the middle. But I think when I talk to people about sort of their barriers and things that, you're spending an incredible amount of personal time and now pursuing a doctoral project about it. Obviously this has touched you in a way that goes beyond just clocking in and clocking out. Is there a time, like, was there a patient that, you ran into this barrier, or a story you heard or something that like really drove this home, when you're like, I need to fix this for that patient?
Yeah. Well, that's a great question, because we all have stories. We do. The one that pops into my head first, it's really a email communication I received from pediatric otolaryngology team. So we used to call them the ear, nose, and throat, or ENT. So that's a specialty, and within that specialty, they're pediatric otolaryngologists. And I know of NPs that work with them very closely. And one of the things that popped up, and this came up because I was having conversations about the CPS number letter, who can I talk to, or who has a specific barrier. And this is what one of them that came up. And it was the referral that made to a child who was discharged from a NICU that had failed their hearing screening. So many of you may or may not know that in California and in many states, one of the things that was mandated to do by the state is to do a hearing screen, not an actual hearing auditory test, but it's a screening test for all newborns. Like 100% of them need to have this test done before they are discharged home from their birth hospitalization. So it doesn't matter if you're going to the nurse in the NICU or you're just in the nursery with your mother. Every one of them should get a hearing screen. And if they are referred, they really need to be followed up and seen by audiology team, and to get further testing to make sure that, of course, as you can imagine, if you have impaired hearing at any level for whatever reason, that can impair your development, especially. So the earlier you find any impairment in hearing, and the earlier you refer for further testing, evaluation, follow-up, and the earlier you get services, meaning if you need hearing appliances, aids, etc., the earlier that happens, the better it is for your development. So I, heard this story about a baby who came out of the NICU, had a hearing screen that was referred. And there is, to make the long story very short, is that in this particular clinic in the community where this patient went, there was a nurse practitioner who could have done follow-up and testing and made the referrals that needed to happen, but it did not happen because of these CCS requirements, because there's a shortage of pediatric otolaryngologists in California. And that's actually been well documented and actually published. So this came to me, and it came to me as a passionate plea that CCS change these requirements so that they can be seen by nurse practitioners in these audiology clinics as soon as possible so that they can get the services and the referrals that they need to make sure we preserve their hearing as soon as possible. And that really touched me because, I don't know personally any young child without hearing, but I've certainly talked to and seen many parents in the institutions that I'm in. And we've all seen them, and they have their hearing aids in place, and we've heard the stories that what a difference it's made, whether your child is going to preschool or just in the home, if you can imagine. And if a child cannot hear what's happening around them, that is such a different world. It's a completely different world for them and for their family. So it's really important. And that's just one of many, many, many examples that I've heard as I've had these conversations.
Yeah. Baby hearing aids are so cute. I don't know why.
I know.
They're
Aren't
all
they?
little.
And glasses, but they need these services
They're
so
important.
bad.
Yeah.
They're so important to development, to brain development, to developmental development. Yes, they are cute and they're absolutely essential. If they're needed, they're absolutely essential.
Yeah, that's hard. We talk about this program sounds fantastic. Like we said, it's already a stressful environment and sort of providing all the support, and then to see something something so important fall through the cracks for probably months. I mean, getting on a physician's schedule if they're impacted can be a significant delay.
Yeah, timing and that's one example that timing is actually quite crucial for their hearing and for their development and for getting the right services from a CCS center. And think about the inequity of this. At first I hadn't thought about it, and someone brought this to my attention, was that the CCS programs are funded by the state because we want to serve Medi-Cal clients and communities. We want to serve lower income clients who may not have the insurance. I mean, I'm so blessed that I have health insurance, but I can't take my son to get whatever he needed when he was growing up. Well, some families need these programs because they qualify. They qualify because of their income. They qualify because of the medical condition of their child. And so if we're unable to support them with this program, with the mandates of this program by the state, then this is causing even more inequity for those families.
Yeah. Of course, these things always have the hardest impact on the most vulnerable patients.
They do.
Yeah,
they do. And so someone should and needs to advocate that the programs are run the way they're intended to meet those needs as best as we can.
Yeah. And I mean, the NP could probably do these like hearing exams in their sleep. That's probably, they're probably doing it literally all day, every day. But it's just some words on a page that says that they can't do it for this particular patient.
Yeah. And more importantly, to refer, even if they're not the technician doing the actual screen or the hearing test, they need to then evaluate the results of that test. And someone needs to make that referral, and that's what the MD and the physician can do. But the barrier to an NP doing it is the problem.
Yeah.
Especially when in a clinic where there's a shortage of physicians, they don't even exist. So we're delaying that referral even.
Yeah. Well, hopefully, I know there's a new numbered letter in development. I don't know what it's going to say or when it's going to come out, but let's cross our fingers.
Yeah. That's the good news.
Yeah.
It is.
Always moving the ball forward a little bit.
Yeah. And we thank California Association of Nurse Practitioners and the entire team, the current president, Dr. Sarana Kwan, and my preceptor who's done a lot of work, Dr. Garrett Ching. This is what moves the needle. It takes some time though. So we need a lot of patience. We need our voice and we need advocacy, but we need a lot of patience because it's a process. We have to speak up, and they wrote letters and they brought these examples to CCS and they're considering them. And yes, we are waiting with bated breath for a new updated numbered letter.
Awesome. Well, I guess on that note, well, hopefully some positive changes in the future. Was there anything that we didn't talk about that you really want to bring up, or any stories that come to mind that you just really want to share?
I think if there's nothing else, I would love to encourage every nurse practitioner, whether you are a new nurse practitioner or a seasoned, experienced nurse practitioner, to use your voice. Some of the work that I have read, there's some really great authors, really great book out there about policy change. Intimidating though it may be, one of the things I found out is that there's a big P, there's a little p. And that little p can make a lot of difference. And the little p is really at your local area where you have influence every single day. There's the big P, that's the national, big state level regulations and laws. And some of us feel as if we can't influence that in any way, but we absolutely can influence the little P, the policies that you literally follow every day. If you see anything, say something. Let's look into this policy. Let's evaluate it. Every policy, I think, should be evaluated and looked at over time just to make sure it's still doing what it's intended to do. No policy, things change so rapidly in healthcare now that sometimes a policy might need to be updated because of those changes. So you can always do something, even if it's a policy in your unit, especially because these are the ones that touch patients literally all the time. If you think it needs to be improved, it needs to be looked at, you have recommendations for changes or updates, just say something and get involved even at that level. So, so key and important. It makes a huge difference. I want everybody to realize that they can advocate for their patients at every level where they are.
Wise words. Well, thank you so much for your time. Thank you so much for patiently explaining this program and some ways that hopefully we can better serve our patients. Yeah, thank you so much. And if let me know in the future if there's any big updates. We'd love to talk to you again.
Oh, for sure. You will definitely stay in touch, and people can reach out to me anytime. And maybe in your show notes, you can give them my email. But if that's something that would be helpful. Thank you so much, Laura.
Yeah, thank you. Have a great day.
You as well. Okay.